Hi, my name is Rachel Sage McCafferty, and today I will be demonstrating a head-to-toe assessment of a patient. The first thing that I would do is check my orders and then gather my supplies and then wash my hands, go into the patient's room, pull the curtain closed, and then identify myself. Hi, my name is Sage and I'll be your nurse today.
Hello.
Then I will ID the patient. I will ask her name and date of birth, and then I will check that on her ID bracelet. I will then explain the procedure and raise the bed to an appropriate working height. First, I'm going to look at her. I'm going to note that she is well-nourished, well-groomed, and well-developed. I will also note that she is alert. She is not drowsy, she's not lethargic, stuporous, or in a coma. I will then check her level of orientation to person, place, time, and situation. Can you please tell me what time of day it is?
I think it's about 5 o'clock in the afternoon.
And where are you right now?
I'm in the hospital.
And who's the president?
Joe Biden.
And why are you here?
I am here to get well.
She is alert and oriented ×4. I will then proceed to take her vital signs. For this video, I will give you the normal ranges for an adult of vital signs. The normal temperature is 96.4 to 99.1 degrees Fahrenheit. The normal pulse rate for an adult is 50 to 95 beats per minute, and the normal blood pressure is less than 120 over less than 80, but we want a mean arterial pressure greater than 65 so that all organs are well perfused. Also, respirations should be between 10 and 20 breaths per minute. With a pulse oximeter, the oxygen saturation should be above 95%. And then I would ask her what level of pain she was having. Are you having any pain right now?
Not at the moment.
Okay, if she was having pain, I would ask her where it was, what it felt like, if there was anything that made it feel worse or made it feel better, whether or not it radiated anywhere. I would ask her the severity on a scale of 0 to 10, 0 being no pain and 10 being the worst pain she's ever had. And then I would ask her how it affected her life, whether or not it affected her ability to sleep or her ability to work, for instance. After vital signs, I would go ahead and start my head-to-toe assessment. I'm going to look at her head. It is normocephalic. It is round. I would then inspect her hair. It is brown. It is well distributed. I will look at her scalp and notice if there are any scales. Also, I'm noting that it is well lubricated, that there aren't any lesions, and that there are no vermin. I will then look at her face. All of her facial features are symmetrical. They have good proportion. I will go ahead and look at her eyes. Her sclera are white. Her iris is blue. And then I will use my pen light to check her pupils. I will be checking Perla, and by doing this, I'm going to put my hand in the middle of her face, moving the light inward. Okay, her pupils were of equal size. They're 4 millimeters. They react to light and they accommodate. Normal pupil size should be between 3 millimeters and 5 millimeters. Next, I would check her visual acuity using a Snellen chart, but I do not have that at the moment. I will note that she does not use any visual aids, so I assume that her vision is 20/20. I will then inspect her ears. Normally I would use an otoscope, but right now I will use my pen light. I will shine the light in her ears, noting that there is not any excessive cerumen, and that on the right side, this is her left side, on the left side the cone of light is at 7 o'clock. On the right side, it is at 5 o'clock. and I would be checking her ears bilaterally. Next, I will inspect her nose. Her nares are symmetrical. I will use my pen light. There is no exudate and the mucous membranes are pink and moist. Next, I will ask her to open her mouth so that I can look inside. Her tongue is midline and her uvula is also midline. Her dentition is straight and clean. She also does not have any lesions in her mouth. Next, I will move on to inspect her neck. Can you sit forward, please? From behind, I will check, you can look straight forward. I will check her trachea, making sure that it is easily displaced with no crepitus. I will palpate for her thyroid, and it is not palpable, which is normal. I will inspect that there is no jugular venous distension. Okay, you can sit back. Now I will note, with a general skin inspection, I will be checking every inch of her body, looking for color, temperature, moisture, texture, any lesions, rashes, nodules, lumps, and when I palpate her extremities, I'm assessing for any paresthesia or numbness. I'm asking her to let me know if she has any pain when I'm palpating her extremities. Like I said, I'm assessing the temperature and the moisture. I would also assess skin trigger by pinching her skin and letting go. And if it has a quick return to normal state, then she is well hydrated. While I'm checking her extremities, I can check her pulses. We have the carotid pulse that I would palpate one at a time as to not instigate syncope. Then we have her brachial pulse right here, her radial pulse right here, femoral pulse inside of the leg, dorsalis pedis, posterior tibial behind the knee, and dorsalis pedis on top of the foot. And I would be doing this bilaterally, and I would be checking each extremity at the same time to note any differences other than the carotid pulse in her neck. After inspecting the skin, I can check her IV site. Let's say she has an IV site right here. I'm checking the dressing. Is it clean, dry, and intact? Are there any signs of infiltration or phlebitis? Infiltration would be a cool temperature, swelling, and there might be some tenderness. Phlebitis, there would also be tenderness, but it would be red. There might be streaking, and there might be a palpable cord. While I'm also assessing the IV site, I'm going to flush it with normal saline to check for patency. Okay, thank you. After assessing the IV site, I can look for, assess any wounds, drains, or tubes. When I'm looking at the wounds, the drains, and the tubes, I'm assessing for any warmth or any edema or any odor that could be coming from them. For the wound, is it well approximated? For the drain, is it patent? Is it intact? And any dressing that is on any of these should be clean, dry, and intact. And this is something that I would document. After assessing wounds and drains, I would move on to assessing her heart. Now, when I do this, I would ask her to take off her shirt so that I can inspect her chest area. Now, when I am assessing the chest, I would be doing everything that I would generally do with any other skin assessment, such as temperature, color, moisture, texture, looking for any lesions, masses, rashes, anything like that. But I would also be looking for chest symmetry. Is her chest symmetrical? I would be checking the AP diameter. It should be 2 to 1. Anything greater would be a barrel chest. Now, I would next, after inspecting, I could palpate and check for the masses and the nodules, but then next I will auscultate using my stethoscope. Now with my stethoscope, I can be listening to 5 areas of the heart. First, we have the aortic area. In the aortic area, that is going to be on the right side in the second intercostal space. Then I would move over to the left side to the pulmonic area, and that is on the left second intercostal space. I would move down to Erb's point, which is on the left third intercostal space. Then I would move to the tricuspid area, which is on the left fourth intercostal space. And last, it would be the mitral area on the left side fifth intercostal space. Now while I'm listening to the heart, I'm checking the rate and the rhythm. I'm listening for any extra heart sounds, such as S3 or S4. I'm listening for a murmur as well. Now, after I have listened to the heart, I will continue my inspection of the chest, moving into the respiratory side. Again, any of the generalized skin assessments, but then I'm also looking for any signs of respiratory distress. Are her nares flaring? Is she using any intercostal muscles to breathe? Is she using any accessory muscles to breathe, and are there any intercostal retractions? Also, I'm noting the rate and the depth of her respirations. Now then, I would go on to auscultate the lungs. There are 5 areas on the front that we auscultate, and there are 9 areas on the back that we auscultate. I will go ahead and note the borders of the right and the left lungs. There are 3 lobes on the right side and 2 lobes on the left side. On the right side, the right upper lobe separates to the right middle lobe from the fourth medial rib to the left lateral rib. And then these 2 points meet together at the 6th rib midclavicular to form the right middle lobe. Below that would be the right lower lobe. Now on the left side, there are 2 lobes, and they are separated by the 5th rib medially and the 6th rib laterally. After auscultating the lungs, I would then go on to percuss. There should be resonance above the lungs. And in the back, when I percuss, I can assess for tactile fremitus, which I would do in the 9 areas that I would auscultate. And I would hold my hands like this and ask her to say 99, 99, 99, and so forth, feeling for a vibration, which I should feel. After the lungs, I will go on to the abdomen. So I would cover her upper chest back up and expose her lower trunk. I would expose her abdomen. I would assess first, in addition to general skin inspections, I'm also looking for any visible veins, any striae, any herniations. After I inspect, I will then auscultate with my stethoscope, and I will start in the right lower quadrant. After the right lower quadrant, I will move clockwise. Right upper, left lower. I will be listening for her bowel sounds. Are they hyperactive? Are they hypoactive? Or are they normoactive? If there weren't any bowel sounds, I would have to listen to each quadrant for at least 5 minutes before documenting no bowel sounds. After auscultating, it is important to palpate. I will palpate and I will feel anything that is not, what is normal is soft and non-tender. So I'd be asking her to report anything that would be tender. After palpating the abdomen, and I would do that in a clockwise fashion, starting in the right lower quadrant. After doing that, I would percuss like this. And all quadrants should be tympanic except for the right upper quadrant. After I'm done with the abdomen, I would cover her back up, and then I would assess her range of motion. Now, for range of motion, I'm going to note whether or not she's doing it actively or passively. As she's doing range of motion, I'm going to be feeling her joints and making sure that there is no tenderness and as well no crepitus or movement of fluids. Now, for the head, I would ask her to extend and flex and circumvent. After that, I would assess her range of motion of her shoulders. I would ask her to raise and depress them and circumvent. For her arms, I would ask her to abduct, adduct, and circumvent. I would do the same things with her legs. Let's go ahead and do it. I will demonstrate. So I'm holding her limbs. Can you please abduct? And can you adduct? Okay. For her hands, I would ask her to supinate her hands and pronate her hands. For her feet, I would ask her to do inversion, and eversion. Yes. And then dorsiflexion and plantar flexion. Yes. With range of motion, I would also assess her gait, whether or not it was steady. I would have her stand up and walk. You're okay right now. And then I would also note her posture, whether or not she was erect when she was sitting up on the side of the bed. A few things that I didn't note when I was doing the head assessment, I would check for the patency of her nose by, did we not get anything? Asking her to close her eyes and close one of her nostrils. Can you do that? And asking her to tell me what she smells.
That's Japanese cherry blossom.
Okay, and then I would do that bilaterally. And then also I would check her hearing using a whisper test. I would have her close one of her ears. And then I would whisper 3 words behind her head so she can't see me. Oh, you're good. Am
I supposed to tell you?
Yeah.
1, 2, 3.
Okay, and then I would do that bilaterally to check her hearing. I think I talked about peripheral neurovascular. When I'm palpating her skin as I'm doing the general skin assessment, I'm asking her if she feels any tingling or numbness, which would be paresthesia. When she did her range of motion, I would have assessed any paralysis that she might have had, any pain when I'm palpating or when she's moving. Pallor, I'm checking the pallor when I'm doing any part of her skin assessment. And then also another thing that I would check is edema anytime I'm on any area of the body. And I would do this by pressing a finger into the skin, and however deep that it pits or depresses into the skin would be graded based on how much edema that she had. I think that's it, Mom. Okay. Following my assessment, I would lower the bed to its appropriate height, all the way down to the ground. I would assess for further needs. Do you have any other needs?
I'm good right now.
Okay, great. I would clean any equipment that I used. I would wash my hands, and then I would document. Thank you for watching today.